As we talk with other clinicians, it's interesting to hear about their practice, what's working, what's not working, and to get new ideas that may apply to us. In a recent interview, I asked Dr. Cindy Howard to share which blood test she uses with patients. Dr. Howard is an instructor for the DABC program, and she lectures at seminars and conferences nationally. Here's my interview with Dr. Howard. Dr. Howard, you do a lot of blood tests. You're a functional medicine doctor, and what are some of the things that are the tests that you think are overlooked, that people forget about or maybe they don't know about?
Oh, that's a great question, because there's the common things we typically run, right, in functional medicine, things like complete blood counts and comprehensive metabolic panels, etc. There's actually 5 tests that I like to incorporate with the majority of my patients, if not all of my patients, that I do think a lot of times we're leaving out that can provide us a lot of information. And the 5 are C-Reactive protein, cholesterol, which I do know gets included, but I do look at it a little bit differently, red blood cell magnesium, homocysteine.
And DHEA, you
told me. DHEA, I did tell you. DHEA.
You did tell me.
Yeah.
We did practice this before.
We did practice
so it's okay.
this. We did.
So C-Reactive protein. Why C-Reactive protein?
C-Reactive protein. I think it's really important because it does a couple things for us. One is it can give us a very early indication if there is any type of cardiac risk or vascular disease. And when we can find things early, they can be addressed then before we actually, have that label of the diagnosis, right? Where the patient is already past that preventative stage. So that's really important. The other thing is we're commonly dealing with conditions that are inflammation-based, right?
Absolutely.
So when we run the cardiac panels and we look at C-reactive protein, the other indication is there a chronic inflammatory condition that, as we know, relates back to cardiovascular too, but quite frankly might play a role in other conditions that aren't heart-related. So we can see that elevation in inflammation and then start to address that as we would any other inflammatory response.
And what about cholesterol? You said cholesterol. That's kind of a surprise.
Cholesterol, is it? So cholesterol, you know what? I look at it very differently, right? Because it gets a bum rap, cholesterol, I think, because we're so focused, right? We're so focused on elevated cholesterol and how harmful it is and whether it's appropriate or not to have certain levels, right? And we're driving cholesterol so low that it's actually causing a bigger problem. So not only do I look at it, of course, if it's elevated, right? It's still a risk factor. But at the same time, I think one of the bigger risk factors is if the cholesterol is too low. So we're driving cholesterol under 150, and I've seen numbers actually even as low as in the 70s in my practice.
It's kind of scary.
So it's very scary. Because now we start to look at risk factors like, is it contributing to memory loss? And even things like dementia and Alzheimer's. We need cholesterol at a very basic cellular level, right?
So it's the cornerstone of all our hormones.
Absolutely. So now, are we producing adequate hormones? So people are presenting with hormone dysfunction or low hormone levels. Let's take testosterone, for example, very common, right? In men who are aging, especially. And now we're wondering, well, what's the underlying cause for that low testosterone? Could it be we don't have enough cholesterol to help manufacture that? Vitamin D, another one, right? So without enough cholesterol, we're not going to have adequate levels of vitamin D, and yet that's been a great one that everybody's been checking over the years as well. And maybe in those patients that we're not getting the levels we want to see, there's an underlying reason, right? I think that's a really unique way to start to look at cholesterol as well.
And how about DHEA?
DHEA. So DHEA plays into hormones too, right? It's a precursor for our estrogen. It's a precursor for our testosterone. Mood, really big, right? So especially with all the dysfunction, whether a patient walks in claiming they have depression, anxiety, any sort of mood disturbance, that can play a role. And again, just another one that's commonly overlooked. And when we can see that that's too low, it's really easy in the functional medicine world to address that. And then, it's got its fingers in other things to help make those corrections too.
And how about red blood cell magnesium versus serum magnesium?
Yeah, right.
I know this is a big story.
It's a big story. And I think even a lot of people aren't running the serum magnesium typically as a rule, right? But we started to run the serum magnesium, and I was even informed from some of the labs that I use that it's not really giving us an accurate assessment of a patient's status in the serum. And the reason being is a lot of times the magnesium will get pulled from the cell into the serum. So we can see that the serum level is normal, and yet the red blood cell level is very low. So that's number one, to make the switch from just a serum magnesium to a red blood cell magnesium. But we're also finding in that functional medicine realm of looking at the ranges, that a lot of the published ranges are actually too low. So we shoot to get that magnesium in the red blood cell level really at or above 6, because what we're finding is people with deficiencies, we're seeing insomnia, we're seeing muscle aches and pains, we're seeing headaches, we're seeing association to anxiety. So when we start to look at the cognitive effects and the musculoskeletal effects, it's pretty profound.
Sure.
And not that, it's a one-size-fits-all magic mineral necessarily, but it's a very common one that we're truly
It's
deficient
like 350 enzymes, isn't it? Something like that? It's definitely in the high hundreds for sure.
Absolutely.
So.
And it's just missed a lot. So, if you're running what I would consider baseline labs, which are probably not typically baseline, right? We're more encompassing. I absolutely throw in that red blood cell magnesium just as a general rule from the get-go.
We only have a minute left. What about homocysteine?
Homocysteine. So homocysteine is a great marker from a cardiovascular standpoint too, and we throw that into a lot of our cardio panels. But the other way I look at it is from a neurodegenerative standpoint. So we love to see that homocysteine at least under 8, if not 6. I love to shoot for even a level of 5, 6 in the homocysteine.
Okay.
Because as you and I are talking, we're neurodegenerating, right?
Sadly, but true,
right?
yeah.
And some of us a little faster than others. And when we see that homocysteine elevated, even if we don't feel that it's associated with the cardiovascular risk, it's absolutely associated with a cognitive function risk. So when we worry about things like dementia, Alzheimer's, or even just general mood,
sure,
the homocysteine can play a really big role. And we know through certain nutrients, especially B vitamins, right, we can start to get that homocysteine level much lower.
This is awesome. Thanks for coming.
Oh, it's always a pleasure.
It is.
Thanks.
We'll do it again.
We will.
All right. Thanks. Dr. Howard is like a walking storehouse of clinical pearls. There's a link on this page for an application for one of our CE accredited seminars. You won't be disappointed. Thanks for watching, and I'll see you next Tuesday.